This podcast has been sponsored by Ardelyx. Maintaining a healthy gut is key for overall physical and mental well-being. Whether you're a health-conscious advocate, an individual navigating the complexities of living with GI issues, or a healthcare provider, you are in the right place. The Gut Health Podcast will empower you with a fascinating scientific connection between your brain, food, and the gut. Come join us. We welcome you.
Hello, friends, and welcome to the Gut Health Podcast, where we talk about all things related to your gut and well-being. We are your hosts. I'm Megan Reel, a GI psychologist.
Hi, I'm Kate Scarlatta. We have an exciting podcast for you today. We are talking all about constipation, a condition that impacts up to 1 in 5 Americans. A recent survey study showed that 3 out of 5 people living with constipation never discuss their symptoms with a healthcare provider. And we are here to change that because there's many new and novel therapies for constipation, including taking vibrating capsules that can help improve your exit strategy.
So our guest today is a professor of medicine at Northwestern University and has Wolverine roots. Go Blue. And I've had the privilege of working with him very early in my career. Dr. Darren Brenner is a beloved gastroenterologist to his patients and has a true understanding for the complexities of living life with GI disorders. Not only does he travel the world lecturing on disorders of gut-brain interaction like IBS, which we talk about a lot, and more, he is a researcher and an expert in GI motility and pelvic floor disorders. We are thrilled to have him with us today, and we have no doubt that everyone listening will be entertained while we explore this topic of not pooping or constipation. So welcome, Dr. Brenner.
Thanks, Megan. Thanks, Kate. Yeah, it's amazing what I do for a living, isn't it?
Yeah. Who would have thought, but we love it.
That's right.
We do love it. All about poop. So
That's
in
right.
the world of gut health, we really like to break through the misconceptions and myths out there because, as you know, TikTok is full of them. So we would love to have your expertise here. Can you myth bust for us? What's something you'd like to dispel with our audience?
Yeah, so I think this is something I see all the time. This is something patients come back with questions and physicians alike. And it's really some myths and misconceptions on things that work and don't work and can be safe or unsafe for treating constipation. And I think we all know that probiotics are very popular, especially in 2024. And this is a multi-billion-dollar industry with almost little to no regulation, especially in the gastrointestinal space. If somebody goes to the store and wants to look for a probiotic, the packages say promotes gut health or promotes gut immunity, but really can't make any claims about this particular illness. And there's been some recent studies that show that up to a quarter of individuals with constipation are trying to treat their symptoms with probiotics, in many cases, probiotics alone. And I'm sad to say, at least in 2024, there really isn't a lot of evidence or data to support that. So I guess that's my long-winded way of saying, if you think probiotics are going to fix your constipation, it's very unlikely. Now, on the flip side is the taboo, and this has been around for 40, 50 years. There have been lots of papers. We're still writing myths and misconceptions about the use of stimulant laxatives, things like Senna or Bisacodyl. We've been told that they'll cause cathartic colon or dead colons or atonic colons or long colons or melanosis coli or colon cancer, and the list goes on and on and on. But the reality of the situation is that in standard doses, these therapeutics are very safe and very effective. So for your patients who are taking standard doses of Senna or Bisacodyl, I don't want them to worry that anything is going to happen to their GI tracts or that these are in any way or shape harmful for them in the long term.
I am so glad you said that because I get that question all the time. And even when I'm amongst other gastroenterologists, I feel like some of them believe that there's a problem there. So, but the expert here is saying, no, don't worry about that. And I think that is really important message for people out there who find that Senna really works for them. And then someone tells them, dial it back. You can't be on that. So thank you for that. That's huge.
It really highlights the individuality of everyone's gut and that your toolbox is going to look different from the next person, from the next person, from the next person.
Absolutely. I mean, I think that's the beauty of what we do. People are always asking for algorithms. We try to put these algorithms together, but Megan, to your point, everybody is an individual unto himself or herself. And so the treatments have to be different. I think that's what makes medicine, especially treating disorders of gut-brain interaction, so fascinating.
That's right.
I agree. So let's just dial it back with constipation. Can you define constipation for the lay audience? Because I have, patients sometimes that say, oh, I didn't poop in the last 12 hours, so I have constipation. Or if they skip a day of pooping, they have constipation. But that's not true, right?
That's right. And it's just like we mentioned, it's different for everybody. And I mean that from a practitioner and a patient standpoint. Unfortunately, to our conversation earlier about TikTok, the lay person has been taught that they have to have one perfect, what looks like a sausage bowel movement every day. And that's just not reality. And I think that's actually more the exception than the norm. And so when we think about constipation, at least historically, we break it into a lot of different symptoms because it's different strokes for different folks. And absolutely, frequency does play a role here. But normal, we have found initially in Europe and more recently in the United States, that about 95% of the US population has a bowel movement anywhere between 3 times a day to 3 times a week. Now that sounds extreme, that norms can be 3 to 21 bowel movements a day, but that is the reality of the healthy average individual in the United States. We talk about texture. I think those of us in academia use the Bristol stool form scale. I think a lot of people and patients who focus on their bowels know what this scale is, but I don't think the average individual does. And it's a scale that defines stool based on its texture. And not to gross anybody out during this podcast, but we really define constipation as things that look like milk duds or baby Ruth bars. And I've been using that analogy probably for 2 decades now, but it's because it really hits home. I think people can relate to what those types of stools look like. We talk about subjective symptoms. Do you strain to go to the bathroom? Do you not feel like you get everything out when you go, which I think is one of the hardest things to overcome? Do you feel obstructed? Do you feel a heaviness or a pressure in your pelvic floor? You feel like you have to go to the bathroom and you just can't get it out? And then the taboo that nobody wants to talk about. Do you need to perform manual maneuvers? And I hope nobody's watching this during breakfast, lunch, or dinner, because I'm going to describe these. Where we talk about manual disimpaction, having to stick a finger into your bottom and try to rake or pull the stool out. Or for women, we talk about splinting, having to take a finger or two and put them in the vaginal cavity and push posteriorly, which reduces all kinds of anatomical variants that can obstruct the stool from coming out. And again, some people will come in with all of these, some 1 or 2 of these. And so it is a different, I would say, du jour for everybody when we meet these patients. I always like to talk about a specific type of constipation because I do see these individuals regularly and I think they suffer for a long time. And these are the people that are defined with diarrhea because they come in and their chief complaint is I have 10, 15 bowel movements a day. When you start to tease out these other symptoms, they say I have 10 hard pellets, or I'm straining, or I feel incomplete evacuation. And what they're really having in many instances is constipation with overflow. There are hard impacted stools at the bottom of the GI tract. The stuff above it gets looser and it finds a way to leak around it. And unfortunately, these people are treated with antidiarrheals, which just makes the process worse. And so in many instances, when somebody comes in and we're not sure if they have constipation or diarrhea, I think your best friend can be an abdominal x-ray because you'd be surprised how many times you will find that there's just a significant amount of stool in the colon, which will identify specifically that this is more constipation than diarrhea.
That's awesome. And when they go in for an x-ray, is it a KUB x-ray? Is that what would they ask for with their physician?
It's a KUB, and I think that can do a couple of things. So I think we see as an overlap for people who are constipated, a lot of abdominal complaints, like abdominal bloating and distension. And these are 2 very different things, and I think you can really differentiate between them with that KUB. Because not only do we see the stool content of the colon, but the gas content. So many times my patients come in and they say, as the day goes on, I look 6, 9 months pregnant, and I'm full of gas. We shoot the film, and I can bring them back to the office and say, look, here's your abdominal x-ray. Here's what the stool looks like. but there's no excess gas, which sends us in a completely different direction.
That's awesome. I'm glad you do that because I think not everyone wants to do those x-rays. And I usually am in favor of them because most of my patients actually have constipation. So it's kind of interesting. So there's different types of subtypes of constipation, IBS-C or chronic idiopathic constipation, slow transit. What's all this, Garb? Can you just break it down like elevator speech on the different types?
Sure. Let's talk about the hodgepodge of how much I can confuse you when it comes to constipation. And I will preface that by saying that when we're in medical school, or I think dietary school or psychology school, what we're always taught is this. If you're not sure what's going on, take more history. And if you're still not sure what's going on, take more history. And now I get to go back to all of my professors 20 years ago and say, when it comes to constipation, that may not necessarily be true because unfortunately, what we have learned and what the clinical trial shows is this. You're not going to be able to differentiate one person's constipation from another based on their subjective symptoms. But it is important to try and figure out what types of constipation are underlying the patient's symptoms because I think the biggest fallacy is that somebody focuses on one subtype. They say, aha, I think you have irritable bowel syndrome with constipation, and they focus right there. And when I think of constipation, I really define it along a Venn diagram because there's a lot of overlap, especially at the academic centers. So if you ask me what constipation is, I'll tell you it's an overlap of 4 different subtypes. And I start with the secondary causes of constipation. And yes, these are things that we can glean from a history and a physical exam. So do you have a risk factor for an obstruction? Are you of colon cancer screening age? Could this be unfortunately a mass or some sort of obstructive physiology? Could it be related to an endocrinopathy? Do you have diabetes, hypothyroidism? Can it be a medication? We talk about opioids and benzodiazepines, but in reality, there are much more common therapeutics out there, especially in the cardiovascular class, beta blockers, thiazides, ACE inhibitors. And then we need to realize that older literature shows that if an individual is on 6 or more medications at any given time, that threshold of 6 increases the odds ratio that somebody will develop constipation. In my world, where I see neuromyopathic disorders, scleroderma, Parkinson's is a huge one, MS, ALS. These are all things we can think about as causes. But I want to caution your listeners, if you can define one of those, don't stop there. Because then we want to think about the 3 other categories. Kate, you mentioned one, irritable bowel syndrome with constipation, and I call this one the trap, okay? This is something that most young individuals come in, they complain about constipation, a little bit of bloating, we snap our fingers, we say, you have IBS-C, let's treat that. And then 40 to 50 years later, they come into our offices and we say it could be something else, like slow transit constipation. The best name in history because it defines constipation because things are moving too slowly through the GI tract. And then obstructive physiology, what we call evacuation or functional defecation disorders, which can be anatomical problems, rectoceles, enteroceles, intussusception, which can anatomically block the stool from coming out. And then the most common one we talk about, which is dyssynergic defecation or pelvic floor spasm or anismus, where the muscles in the pelvic floor do not work. And so when you try to go to the bathroom, instead of those muscles opening up to allow stool to come through, they may open a little bit, not at all, or go into spasm and impede the ability of stool to come out. And it's very important early in the course to define this disorder because this is the disorder that will not respond to therapeutics like laxatives. And I think we're going to come back to this a little bit later.
And it won't respond to some of our behavioral strategies. It really requires then bringing on that pelvic floor physical therapist. And so you make such a huge point here that especially we see this constipation more prevalently with women. And so if they're told you have constipation and then they're not consulted by a pelvic floor physical therapist or their gastroenterologist hasn't done a physical exam or some of the additional workups that are available like diphography or anal rectal manometry, these patients are going to suffer more for longer. And that's a disservice.
And that's part of our concern as practitioners. Our algorithm hasn't changed in 20, 30 years. And when we talk about diagnostic testing, the average individual will probably get a colonoscopy. But the first test recommended is anorectal manometry and balloon expulsion testing. Realistically, the first test recommended is a digital rectal exam, but I think we do a very poor job training our trainees on how to do that. So I always say the digital rectal exam is only as good as the finger that's performing it. And thus, if you're not comfortable doing that exam, we really don't want you invasive. We can use the anorectal manometry to better define anorectal physiology. And Megan, you opened that door talking about the pelvic floor, and I will walk through this door anytime I've given the opportunity. So please allow me to tangent a little bit, because I always say in my lectures, and I always say when we're talking about these types of things, I want to talk about something that's near and dear to your heart, and that is a history of trauma, whether it be physical, sexual, or emotional trauma, or abuse. Because the reality is the vast majority of practitioners do not ask about this, and this plays a fundamental and key role in constipation. Because the reality of the situation is this: if your patient has a history of physical, sexual, emotional abuse, or has undergone or gone through some form of trauma, and they have constipation, the pretest probability that their pelvic floor doesn't work, based on clinical literature and anecdotal experience, is higher than 90%. And while with pelvic floor problems, we recommend the physical therapy, the reality of the situation is if we do not mind, pardon the pun, that brain-gut connection, these patients with physical therapy have little likelihood of success for improving their constipation symptoms. So I beg all of your listeners, I beg all of my colleagues around the world, when you see a patient with constipation, ask about this, because you will have to target and focus on that brain-gut interaction associated with the trauma as well.
That's such an important point. And to your point, sometimes we're not comfortable doing the rectal exam, and then there's an even higher prevalence that are not comfortable to have that conversation. And so I also beg of you as a listener to advocate for yourself, to let your physician know if you do have a history of trauma. And even if your provider hasn't necessarily asked about it, they likely will be very able and capable of making your experience with either your medical procedures or subsequent questions more comfortable. So it's a two-way street. You know, we want people advocating for themselves, but it's such a good point that physicians, especially in this area, and primary care doctors and NPs and APPs, we do have to be very mindful of that connection between our brain and our gut and our life experiences.
And please do advocate for yourselves. I ask all of my patients, as a matter of fact, if they have a history of trauma, I let them see the manometry catheters, feel them, touch them, know the experience, walk through the process, because in many cases, these individuals are not comfortable undergoing the procedure, and they're not going to be comfortable undergoing pelvic floor physical therapy. It is a very invasive intervention, and they have to be aware of what's going to happen within that clinical practice. And in many cases, and I thank you and all of your colleagues for this, brain-gut behavioral therapists get involved, and we start there, and then we go backwards to the diagnostic testing and the treatment associated with pelvic floor dysfunction.
And even if you're somebody that doesn't have a history of trauma and you're feeling a little bit anxious about a doctor that says, okay, I'm going to do a rectal exam now, or, you know, it's time for a colonoscopy, you're not alone in feeling anxious about this. And we even in our book, Mind Your Gut, we put in a colonoscopy coping kit to highlight, you know, that you could ask for certain music, you can do some breathing exercises, you can ask as many questions as you want to your gastroenterologist prior to any of these procedures, and you'll feel more comfortable. So those with a trauma history, and certainly the many that do not have a trauma history, we want you to be comfortable. Your relationship with your gastroenterologist is about as close as you can be. And so you want to have a really good therapeutic dynamic across the spectrum of your time working together.
I love that. And I would say, you know, I love that you show or go through the testing with your patients, because I certainly had patients just arrive at the testing and like, what are we doing here? So I think if you're a listener as a patient or you're a listener as a provider, it is important that you ask what the test entails. And as a provider, I always prep my patients like, this is the test. This is what they're going to be looking for. It's important part of understanding your pelvic floor, but expect the following so that they can decide, or at least be prepped and not surprised. So one other question I wanted to talk about, you have an individual with constipation. What are some other red flags that would really prompt you to say we need to do further investigations here? Something else is going on beyond just constipation.
Yeah, great question, Kate. I think first and foremost, if you're over the age of 45, request that colonoscopy, because I can pretty much assure the gastroenterologist is going to want to do that. That is the new screening age, and we're going to want to take a look to make sure there's nothing obstructive. Now, that does not, and I stress the term not, mean that if you come in with new onset constipation over the age of 45, that it is due to colon cancer. I have found that very, very infrequently in my career. As a matter of fact, having probably seen 20,000 people with constipation, I can find the number of colon cancers that I have identified on less than 2 hands. Okay, so I don't want you to worry, but that would be the first thing. Let us know if there has been recurrent or an increase or crescendo in bleeding. If this is an acute change, if there's unexplained or unintentional weight loss. These are big triggers that we want to know about. These are things that may indicate something else may be going on. But think about lifestyle factors as well. Have you changed your diet? If you change your diet, you shift your microbiome. If you shift your microbiome, it may change the motility, secretory, and sensory patterns of your GI tract. Or have you tried a new medication? Like I said, we talk about the big ones, but there are hundreds of medications out there that can cause constipation. So let us know, and let us know if something has changed, because we may be able to correlate that specific change with your new onset symptoms and allay your fears very quickly.
All right. So those are those red flags. And our listeners are going to get really good at understanding what those are. Again, we don't want you to have a ton of anxiety if you do have a red flag. It just is a good indicator that, hey, you need to check in with a doctor, and we'll go from there. It doesn't have to mean that there's a cancer. And that certainly is something that a lot of people stress about, which leads me to a segue here to the brain-gut connection. So you've mentioned this. Constipation can be a disorder of gut-brain interaction. So tell us a little bit from your gastroenterologist brain and perspective, how does the brain-gut connection impact constipation? And tell us a little bit about what stress does to that.
Yeah. So, when I think about the brain-gut connection, I think about stress as it relates to constipation. I really take it out of the, what I like to call slow transit constipation component. Irritable bowel syndrome, we all know that stress exacerbates those symptoms. And I worry about my stress patient when it comes more so to the disorders of the pelvic floor. And then I get into what I call the sick cycle. Pardon the pun again, but I think we as practitioners for many years have poo-pooed constipation as a nuisance disorder. And if you really take care of these individuals, you see it's much more than that. It significantly impacts quality of life. I can't get out of my house. I can't leave the porcelain throne. I spend 6, 7, 8 hours a day on that toilet. And when I'm not on the toilet, on the couch, perseverating about said toilet because I feel like there's still stool in there. I'm afraid to go somewhere. What if I get the urge? What if I'm out to dinner with my friends and I'm in the bathroom for 30 minutes? Is somebody going to come checking on me because they think I fell in the toilet or somebody flushed me down the drain? These are things that realistically I have heard over and over again. And the problem is when you start to feel the stress and you start to lose the quality of life from those types of symptoms, that can increase what we see in the pelvic floor. Spasm of the muscles or an inability to relax because the brain talks to the pelvic floor. You have to coordinate these two. Just as much as I'm moving my hands right now, these are skeletal muscles. I'm coordinating them in a voluntary but very involuntary manner. I'm not thinking about it. I have no idea what muscles these are anymore. I forgot that a long time ago from basic anatomy. But the muscles that I'm wiggling in front of all of you right now are identical to the muscles in my pelvic floor, the puborectalis and external anal sphincter that I learned when I was potty training to open up and close. And these muscles, if I have these types of stressors, may not want to open anymore. And that leads to an increased burden of stress, which leads to more tightening of the pelvic floor muscles, which leads to increasing stress. You can see where I'm going with this, and becomes a cycle. And I call it break the cycle. But here's where Kate comes into our pyramid here, which is when you have all of that constipation and you feel horrible, you don't want to eat. And you may develop symptoms like ARFID, or eat less. And so because you eat less, you lose weight. And as you lose weight, your GI tract slows down and you lose motility, which means when you eat, you feel even worse. So you eat even less, and then you lose even more weight. And then you get to a point where you don't have enough muscle mass to impact or to work the muscles in the pelvic floor. I see lots of patients who come in and they say, I know my problem is my pelvic floor, and I've been to physical therapy, but my physical therapist can't fix this. And I'll tell you, in my academic program, if your BMI is less than 16, my physical therapist won't touch you because there's not enough muscle down there to fix. So this becomes a cyclic spiraling process. And the problem I think that we fall into is we don't understand how to explain this to patients because we go directly to the weight. And it's critical, and we have to fix that. But here's what patients hear no matter what you say. You think I have an eating disorder. No, I don't. What I'm saying is that weight restoration is key, and you fall into this process of low weight, inability to eat, pelvic floor doesn't work, stress making this all worse. And from my standpoint, when we're looking at a cyclic process, I don't want to break the cycle at just one point. I want to blow up that cycle. And I think the best way to do that is to engage all of us, physician practitioners, behavioral therapists, psychologists, and dietary experts, because that's really the only way we're going to get them better. So I like to say, can stress play a role at the beginning? Yes, I think more so in irritable bowel and pelvic floor. But over time, constipation can lead to more stress, which leads down this pathway of doom, as I like to call it. But we can fix this problem.
We can bust that cycle.
I think the notion of restricting food, patients don't realize that that impacts the motility and is going to bring them down. Like, your efforts are going backwards. You're not going in the right direction. That whole motility effect, it's a muscle. It needs nutrients and fuel. And that message hasn't gotten out to them strong enough, I don't think. And I'm constantly saying this to patients. You need the energy for your body to work. It's just so important.
Even there, when we talk to practitioners, to put this in a little bit more technical terms, I tell my patients, even if you can just eat a little bit, try and graze throughout the day. It's the gastrocolic reflex. Patients go to the bathroom, or I should say patients, individuals go to the bathroom first thing in the morning and after meals. When people come in, they say, I eat and I poop. That's completely normal because it's that reflex. That's that increase for the practitioners of high amplitude propagative contractions. And then we have medications that we use that activate GCC receptors, the secretagogues, like linaclotide, plecanatide. These are activating the same mechanisms that food does to help us go to the bathroom. So at the end of the day, having a bowel movement, food is key and essential.
Absolutely. Good point.
And the dream team approach of incorporating several different multidisciplinary specialists is so critical here, because it is anxiety provoking when you've gotten into this cycle. And that's where, in addition to your treatment as the physician, Kate's treatment as the dietitian, my treatment as the psychologist, we're going to utilize cognitive behavioral therapies that are specific to those GI concerns that you have, the avoidant behaviors, the fear of reintroducing food. So there are treatment options out there to certainly break these cycles. It's just a matter of getting into the hands of that right team. And so if you haven't found that, and Dr. Brenner is explaining the cycle and you're listening and just nodding your head going, yes, 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 that's me, keep reaching out for those strategies. And even in our book, we give you a ton of resources to help create your own dream team.
And Megan, if I may,
yeah.
I'm sorry, if I can add one more point, I apologize. Just for the practitioners and the patients alike, if you have this type of constipation, please, from the practitioner standpoint, be honest with your patients. Tell your patients you can't fix this alone. Patients, don't expect the practitioner to be able to fix this problem with medicine. It doesn't work. So we have to be realistic in this process.
Yep. We have to all work together for the sake of the patient's well-being.
IBS-C, or irritable bowel syndrome with constipation, is a common condition in which people experience constipation along with other belly symptoms like pain, bloating, and discomfort. Sound familiar? Many people with IBS-C are willing to give up key parts of their lives in exchange for symptom relief. And because the causes of IBS-C may differ for each person, there is no one-size-fits-all treatment approach. If you're suffering from IBS-C, you may have to try a number of different medications before you find the right one for you. So don't be okay with just feeling okay. If you have IBS symptoms that continue to bother you, talk to your healthcare provider to find out if your current medication is right for you, or if it's time to try something different. The more you know about IBS-C, the better prepared you will be to speak with your doctor about the right treatment option for you.
And as we shift to some other kind of potential factors when it comes to constipation, can you talk a little bit about intestinal methanogen overgrowth and its potential relationship to constipation? What is it? How do we test it? How do we treat it?
What is it? That's hard to define. I think we're in the fledgling stages of understanding these things and truly understanding our microbiomes. People come in every day. They're like I said earlier, can I just take a probiotic, fix my microbiome? I do personally think that the gut microbiome is the gatekeeper to everything, not just GI, allergy, immunology, pulmonary issues, rheumatologic issues. But the reality of the situation is, I'm going to minimize, and I don't mean to, it's not as simplistic as the human genome where we can map it. The gut microbiome is different for everybody, and it changes with very simple perturbations. Like I said, just as simple as changing our diet. So I think we are really in the fledgling stages. We're at the base of the iceberg and understanding it. So I don't think we know it well enough to manipulate it. But one thing that has been elucidated is this idea of EMO. And I'm glad you bring this up, Megan, because I think everybody just lumps this in to the SIBO category. And it's not. It's something completely different, which is why the acronym has changed. Remember, ladies and gentlemen, SIBO is small intestinal bacterial overgrowth. Now, I stress the small and the bacterial because when we go to EMO, those disappear. EMO is intestinal, i.e., it may not be in your small intestine, it may be in your colon. Methanogenic, these are not bacteria, they are archaea or primitive single-celled organisms that overgrow. And so you can find these things in the GI tract. And they are methanogens, meaning that they produce methane. And methane has been shown in clinical trials to slow gut motility. So I think about these as a potential trigger for slow transit constipation, but they're also associated with some of the abdominal symptoms you experience, like the bloating and the distension. And in many cases, they are treated differently than SIBO. So people come and they say, I've been treated for SIBO and SIBO and SIBO and SIBO, and it's not doing anything. And it may be because it is not, again, small bacteria, but intestinal methanogens. Now, the best way to test for these right now is with breath tests. And you can use glucose and lactulose breath tests. And these are done in some clinical practice or academic center labs. But there are multiple proprietary institutions out there that you can get this kit and do it at home while you're watching TV on your couch. The accuracy of these tests, from my standpoint, still has yet to be elucidated. So I do like to tell everybody, if you get a positive test for SIBO or EMO, don't put all of your eggs into this basket. Like I said before with the Venn diagram, do not focus solely on this. This may not be the only problem or even the problem that is causing your symptom profile. And I mention that because I see a lot of patients who come in and they're like, I have constipation because I have intestinal methanogenic overgrowth. And then I do a couple of different tests and I say, you may have intestinal methanogenic overgrowth in EMO, but there are a few other things going on that we have to focus on as well.
That's right.
Like, is it the chicken or the egg? Like what's causing this EMO? A motility, something else, right?
Right. Where is it matters. Because when we think about treating, and we treat primarily with antibiotics, there's some herbal therapies that have some data, some studies we did recently in Northwestern for an herbal called Atrantil. But the therapeutics and what you're going to be able to use to impact EMO is probably going to be shown to be quite different than what we use for SIBO.
Can you just talk a little bit about Atrantil? Because I get a lot of questions about that. In your study, did it reduce methane? I know there was a reduction in bloating, right? But did it reduce the actual methane levels as well?
Yeah, it's a really good question because that's what we're looking at. We're looking at symptoms and correlations to methane responses in two different fashions. One was, did it just absolutely reduce methane? And two was, did it lower it below the threshold of normalcy, i.e. 10 parts per million? Now, I will say, truth in advertising, this is a small study. It's an open label study. It had to be done in 1 year, and it was done during COVID. And so every patient who got a Trantyl knew that they were getting a Trantyl. So it wasn't compared to placebo. But I'm fine with that because I call this a case-based real world analysis of this type of therapeutic. And that's what people are doing with probiotics every day. We use the NIH promise scales as our threshold to determine who responded. And we wanted to because if we're truly treating intestinal methanogenic overgrowth or EMO, we don't expect it to improve some of the other promise items like reflux or dysphagia. And it didn't. What the patients responded to was we saw significant improvements in bloating and abdominal distension and discomfort, and a very close trend. It didn't meet statistical significance, but it was close for constipation, the cardinal symptoms of EMO. We also looked at adequate relief. We know this is a validated endpoint. The vast majority of our patients had irritable bowel syndrome, were positive for methane, and more than 50% of patients endorsed adequate relief at the end of a month of treatment compared to how they were at baseline. The nice thing is the safety profile. We had really no serious, severe adverse events whatsoever. The interesting part was we saw really no changes in methane, no absolute changes over time. And certainly there were only about 3 or 4 patients that dropped below the 10 part per million threshold. Now, the vast majority of patients that we enrolled weren't very high above that threshold. The parts per million was in the probably 10 to 20 range. So there could have been a floor effect, but it also begs the question with this therapeutic, which does contain some bark. Peppermint oil, I think many of our practitioners and listeners are familiar with what peppermint oil can do. So some things we don't know a lot about, some things we do, but very natural interventions. These are the things that we're trying in these patients.
Awesome.
All right. So you mentioned this. You're starting to talk a little bit more about the potential things that patients can try to help with their constipation. And one thing that we frequently hear is fiber. So do you have a go-to fiber supplement as a gastroenterologist that you feel comfortable recommending to your patients? Or do you just send the patients to one of your fabulous dietitians and have them help with fiber intake? What's your approach?
So my dietitians are fabulous. But if I sent everybody who needed fiber for constipation to them, woe to the patients who really need to see them. So yes, I do have a go-to. And I think in GI, there are 2 schools of thought, people who believe in fiber and people who don't, at least based on studies that came out of the University of Michigan, where you practice, looking at what practitioners, specifically gastroenterologists, recommend as first and second line interventions. So I will give all of these as synonyms for the one I use. Plantaga ovata, Isfagula. In my world, ground up corn husk, okay? Psyllium, soluble, minimally fermentable, gel-forming fiber. I think this is the best. This is my go-to, and this is the one that I recommend based on clinical literature and clinical experience for patients with chronic constipation and irritable bowel syndrome with constipation. Now, the vast majority of the people that I see do come in with a complaint of bloating and distension. And I don't minimize that even this one has the potential to cause this. So I always start with the old start slow and low and titrate from there. I do not try to pound 20 to 30 grams of fiber as recommended by everybody into somebody on the first day. They will blow up like a balloon and want to kill me.
Yes.
I've had this experience. I have tried the different fibers and supplements at DDW and then laid on the floor miserable because I'm not afraid to share the fact that for 20 years I have suffered from post-infectious irritable bowel syndrome. So I am not only a patient, I'm also a client. And if I use fiber, this is the one I use. I think it is the most effective with the least likelihood to give gas and bloating. And again, I start very slow, a couple tablespoons a day with meals, and I work my way up from there.
Perfect. So take heed so that you too are not on the floor, low and slow, and work your way up to the proper daily dose. And then when do you escalate from some of these? Because that's over the counter, right? We can get over the counter supplements and medications. When do you escalate to something like some of the prescriptions you've mentioned earlier?
Yeah, I'm a big fan of over-the-counters. When we published our systematic review a couple of years ago on all the over-the-counter therapies, I'm a big fan of PEG 3350. Everybody starts there. So if they don't want fiber or they fail fiber, everybody starts there. Now, when I say a fail fiber, I'm also talking about Kate's dietetic interventions. So I talk about kiwis, mangoes, prunes. With everybody that walks in the door, I know our dietitians are big fans of chia seeds as well. So I do like people to go healthy and natural first. When people fail PEG, that's when in many cases I will start thinking about the prescription therapeutics. That does not mean that I'm anti-Senna or Bisacodyl. I use these more as rescues. I'm not adverse to magnesium. A lot of my patients have already come in and failed magnesium because it's a natural supplement and they've tried it. But where I really start to differentiate is with the severity of the abdominal symptoms, the pain, the bloating, the discomfort. Because unfortunately, with respect to the over-the-counters and with the exception of the soluble fibers we just mentioned, none of the over-the-counter therapies have ever been shown to improve abdominal symptoms. And in fact, in the clinical trials, some have been shown to worsen them. So when somebody walks in the door and says, my predominant symptom is pain, discomfort, and bloating, yeah, I can get my bowels under better control, the frequency, texture, straining, incomplete evacuation with the over-the-counter. That's when I go to the prescriptions because the data is much more robust for helping those abdominal symptoms.
Awesome. I don't want to get totally into brands, but is there one that's more first line?
Yeah, for the prescriptions, Kate, it comes down to my 4 C's, but I'll focus on the first 2, which are cost and coverage.
Yeah.
In many cases, unfortunately, in 2024, and I think all of us practitioners hate this, what we prescribed is dictated by what insurance gets as their initial tiers, and that's what we have to give these individuals. And the differences can be hundreds, if thousands of dollars. And so we're a little bit restricted in that process.
Yes.
So realistically, that's my go-to.
Yep. That makes a lot of sense. I know. I just switched insurance, so I'm hearing you. It's like a whole new world. I'm trying to figure out what's covered and what isn't. I don't think I'm going to let go of the milk dud analogy earlier. I keep thinking that was like one of my favorite candies growing up. So yes, if you are experiencing poops that look like milk duds and you have constipation, as Dr. Brenner has explained very beautifully, there are some diet and lifestyle interventions that I often will use with my patients. So in individuals that I consult with. So I'm just going to briefly run through some of these as a review. Green kiwi fruit is my go-to. And I tell people to buy it in bulk, wash it, chop it up, keep it in your freezer. It's you can just throw it into a smoothie. It's 2 green kiwi fruit that have the best sort of efficacy. You can keep the skin on in a smoothie. You're not even going to see it or taste it, and it's fine. It's extra fiber for you. Mango has excess fructose, which is very osmotic. So Dr. Brenner mentioned that. Sorbitol containing foods like prunes or apricots, peaches, those also have a lot of osmotic effects, pulling water into the gut that may soften up your stool. I am also a huge psyllium husk fan. So I add it to my smoothie and I just go titrate slow. I get Kate Farms. It's a powdered psyllium husk, and about a teaspoon is 4 grams of fiber. I think that's a great starting point for most people. And then you can titrate that up to kind of see where you are. But as Dr. Brenner mentioned, it's soluble, which tends to be a more tolerable type of fiber. It's not adding a lot of bulk to the stool. We already have a lot of bulk to pass. It's low fermentable, which is great. And then that viscous property is great because it sops up extra fluid, softening stool. It's low fermentable, so it stays intact in the colon to do the job that it does. So that is absolutely my favorite. The other idea is a squatty potty. If you talk to any GI dietitian, they all have them, including me. I have a streamlined one that's kind of see-through, very, very posh. But we talk about the proper poop position in our book on actually page 329, so that you can kind of see, you want to raise those knees above your hips, open up that rectal canal angle, and let things flow a little bit more easily into the porcelain throne. I love that. Always make sure, as Dr. Brenner mentioned, fiber should be titrated up slowly. Let your body adapt. There's a big ecosystem going on, trillions of microbes in the colon, and they're going to love that fiber you're upping in your diet. So just go slow, lots of fluids to have your body adjust. And then exercise is another really good thing. So keep your body moving. I think a good long walk, a lot of people will be like, oh, come home and be ready to hit the toilet. So I think that's important. And another really important point that Dr. Brenner mentioned was eating regularly. So we do have that gastric colic reflux after we eat that stimulates colonic motility. So if you're skipping to avoid symptoms, you're not going to take advantage of that gastric colic reflux. So eating regular meals is key. So that's my little spiel. Dr. Riel?
I have a couple thoughts, right? And I'll say, so this was probably 13, 14 years ago. I was standing in the hallway with Dr. Brenner and I actually asked him, this was when I was a very, very junior GI psychologist. I said, hey, is the squatty potty like a real thing? I saw it on Shark Tank. And he said, yes, I endorse this thing. So it was actually from Dr. Brenner where I was able to really, remind our patients of the value and importance of our posture and our behaviors while on the porcelain throne. So thank you, Dr. Brenner. A couple other words about, as you mentioned, we go back to that cycle that people get into. And recognizing that stress can be a big factor. And sometimes the stress is completely related to just your bathroom habits. And so if you're somebody that does, you're afraid to go to the bathroom at work because you're like, people are going to wonder what I'm doing in there. And we have poopery now. So it's so important to not miss your body's cues that it's time to go. And when you do, you start to really impact that brain gut connection where the brain is saying like, hey, we got to go. I got signals from down below and you're not going. So now I'm going to have more clenching, spasming, anxiety, pain. So it's so important that we listen to those cues. And the other side of this is really about balance that, if you're having constipation, balance in life in general, which is good for all of us, whether you have constipation or not, is so key. And so that comes in the form of self-care. And so practicing relaxation, and you can really up this by doing gut-directed relaxation or gut-directed hypnotherapy, which is actually an evidence-based behavioral therapy to help with the management of constipation. Even if you don't have access to a GI psychologist to guide you through this, the world of digital behavioral therapeutics is evolving. And so there's an app that you can download now, the Nerva app, that's a gut-directed hypnotherapy app that provides you with a behavioral strategy to really address the restoration between the brain and the gut that can become so dysregulated with our gut health and, for a variety of reasons, as we've hit on, whether it be our nutrition, our stress, the mechanics of our toileting and our motility. So there's lots to consider here, and finding that balance through both movement and relaxation. You guys have all heard me already talk about the benefits of diaphragmatic breathing, but that's a beautiful strategy that can help to quickly break that stress cycle while you then can employ a variety of other techniques and strategies. So we just want to be mindful that constipation is not a one thing is going to fix it all a lot of times. And so we hope that our guest today, Dr. Brenner, gave you lots to consider and maybe ponder while you're on that porcelain throne, but don't ponder for too long. A lot of times with constipation, people are sitting on the toilet for far too long. And maybe, Dr. Brenner, how long should somebody sit on the toilet before they decide, now's not the time, and they get up and go?
I usually tell people 5 to 10 minutes, then override your brain. You can override, lift your legs and walk away. And I want you to do that. And a lot of times people have a lot of difficulty. And Megan, that's where you can come in and help assist some of these people. It's getting over that perseverative piece and overriding that urge, knowing that you will try again later and hopefully have more success at that point.
Perfect. All right. Well, I have learned so much from you today, and I hope our listeners have too. And as we wrap up this episode, we like to ask all of our guests the following question. Okay. What is something that you, Dr. Darren Brenner, prioritize when it comes to your own overall health and wellness? What do you do?
It's a great question. I will honestly and wholeheartedly admit that I spend all day recommending to all of my patients that they eat these very healthy, balanced diets. And I know the two of you have broken bread with me in the past, and I'm probably anything but. I love my food. I love my junk food. There's the live to eat and eat to live, and I live to eat. So I focus on the exercise aspect, as Kate mentioned. People tell me all the time, I just can't find the time to exercise. Please, 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 please make the time. 30 minutes, an hour. Just get up and go for a walk. I will do my workout if I have to at midnight and then go to bed. But it's amazing how much the exercise can help, just not in the gut motility per se, as you mentioned, but also on the psyche side and the way you feel. I wake up every morning the next day feeling much better if I worked out than if I hadn't. And I think that alone can be a major contributor overall to not only your gut health, but just your health in general.
So this man is one of the busiest. We were lucky to grab time from him, but I think it just begs to kind of show the benefit that even if you are living a very, very busy lifestyle, prioritizing your own time for self-care and moving your body, it's going to give you the endorphins. It's going to help you be more productive in your day-to-day work life, school life, mom, dad life. Thank you for elucidating the benefits of that.
Yes, I love that. I'm all about the exercise too, but I'm going to work on, I think we're going to have a little nutrition consult the next time I see you. Just a little, what we call a gentle diet cleanup.
Which is funny, Kate, because I'm going to call you out here because the next time you see me, we're sharing a dinner at Fogo de Chão, the all-you-can-eat Brazilian steakhouse.
I know. I'll have to clean up my act that evening. That is so funny. It's true. Oh my goodness. This was phenomenal and so helpful on so many levels. You've covered everything, I think, about constipation and more. So thank you so much for coming on, Dr. Brenner. We appreciate your time, especially knowing how busy you are, and keep making the GI space a better place to work in. Keep doing that wonderful research. It's making a difference in the lives of people living with GI conditions. So thank you.
It's my pleasure. And thank you for having me. I really do appreciate it.
Thank you for joining us as we grow this gut health community. We hope you enjoyed this episode, and don't forget to subscribe, rate, and leave us a comment. You can also follow us on social media at The Gut Health Podcast, where we'd love for you to share your thoughts, questions, and experiences. Thanks for tuning in, friends. Thank you for joining us as we grow this gut health community. We hope you enjoyed this episode, and don't forget to subscribe, rate, and leave us a comment. You can follow us on social media at The Gut Health Podcast, where we'd love for you to share your thoughts, questions, and experiences. Thanks for tuning in, friends.